So I want to start this conversation not talking about malaria, but smallpox. On the left-hand side, you see the last documented case of smallpox from the original endemic transmission that plagued the world from a very long time ago, and the declaration that came 3 years later that smallpox had been eradicated. Now, I want to ask this question that sort of Scott Barrett and others have written, but mostly Scott Barrett has asked the question, what exactly were the economic benefits of smallpox eradication? And so there were two big benefits. One was that about 1.5 million cases, deaths from smallpox were averted. And once it was done, you could end smallpox vaccination programs. That is, nobody had to be vaccinated for smallpox ever again. Well, what was the counterfactual? What were you comparing that against? Well, it was a massive international program to avert most of those deaths, but an ongoing smallpox vaccination program. So the cost savings was really that you could end smallpox vaccination. And when you take all of the costs of eradicating smallpox and add them up, and you compare it to the cost savings of being able to abandon your global smallpox vaccination program, all the costs, it turns out that about 28 days after that last case, and after they could start dismantling those programs, 28 days later, the whole program had paid for itself. And then it paid for itself again, so that the cost savings ratio was about 160 to 1. That is to say, we've saved about $160 for every dollar we spent on the smallpox eradication program, which is certainly one of the greatest investments in public health ever made, or in economic development ever made. And this is a very tempting prospect. Now, it may not be that other diseases have such a high cost-benefit ratio, but it's important to note two things, that the economic benefits really did come from ending vaccination. I've said that 3 times now. I want to make sure that you understand that that's what the benefit was, right? So even if we eradicated measles, we wouldn't recoup a massive savings from all of that unless we could stop measles vaccination programs, for example. And it only came, therefore, after there was a last case. So once that last case was gone, there was no further risk of smallpox transmission in the wild, and it would then be okay to disassemble your programs. So the problem with this argument is that it makes it seem like eradication programs are a very risky prospect, and maybe in some cases there are. But I want to kind of address that framework for malaria and argue that I don't think it's the right way to look at malaria eradication. And I'm going to do it through a historical lens. So in particular, the first global malaria eradication program failed, which would say that it would probably be risky to try and start it again, okay? And this gets into a bunch of questions. Why eradicate malaria, or better said, why attempt to eradicate malaria? Is it worthwhile to start an eradication program? What does the history of malaria say about the prospects for the future? And is it really a risky strategy to attempt to eradicate malaria? So if you were to separate the whole history of malaria into sort of 5 ages, the first age is everything before 1900. Or maybe you'd want to even separate it finer into the germ theory of disease discoveries and everything before that. But I'll start in 1900, shortly after Ronald Ross demonstrated the role of mosquitoes in transmitting the parasites. And once you knew the mode of transmission was a mosquito, you could go out and start to do control measures. And Ronald Ross himself has a book called Mosquito Brigades and How to Organize Them. So the very early 1900s. And then there were these massive efforts to go out and control. So one of the first was, starting in 1904, the program for yellow fever and malaria control in the Panama Canal, led by William Gorgas. And a couple of details like this are really relevant. One is that when Gorgas took over the program, the Canal Commission thought that they were nuts to focus on mosquitoes. They didn't actually believe mosquitoes transmitted malaria. So there was then a decision to replace the Canal Commission, led by Teddy Roosevelt. And because that initial Canal Commission didn't believe mosquitoes transmitted malaria, they wouldn't grant a budget. So there was about a $1 million budget request, which was a lot of money in 1904. And the request was granted in 1905, and almost immediately after they started implementing these control measures, they saw a decline in the number of yellow fever cases and malaria cases. And, and this was seen as one of the major public health successes, that the canal construction wouldn't have been possible without it. One of the, I'm going to skip over a lot of history in that early days, some of it relevant. The main point is that in this first age, there were very, very few cases of malaria elimination from any countries of the world. But one of the great successes was not a malaria elimination program, it was an anopheline eradication or elimination program. So this is an emergency graveyard in Brazil, in Ceará, the state of Ceará, in 1934. It was built for malaria victims. What had happened was earlier, probably about 1930, a boat had introduced Anopheles gambia, the African vector, below a dam, sort of in that part of Brazil, sort of coming from Senegal. And that vector, that African vector, had started to spread along the coast. And by the time somebody got around to, it was observed and documented in 1930, the epidemic started, and they got around to doing something by about 1938. And by that time, it had occupied an area about the size of New England. The man they called into it, control it, was called Fred Soper, and he organized mosquito brigades with larval source management, and through a sort of military-style, top-down program, they were able to eliminate Anopheles gambia from Brazil. And malaria didn't go away, but the load of malaria went back to where it was before. It wasn't an emergency like it was when that had happened. And this left Fred Soper in a position of being, one, very powerful and very sure of himself. And he said, famously, man has it in his power to eradicate any mosquito anywhere. So we're talking about the end of the first age and the beginning of the second age, the first age of eradication, where Soper is now one of the biggest people in the world, and we get this combustible combination at the end of World War II and this post-World War II enthusiasm for development, the discovery of DDT, the availability of chloroquine, which was a cheap and effective anti-malarial, and this led to the launching of the global malaria eradication program. So DDT had been known as a chemical for a long time, but its insecticidal properties were demonstrated in 1939. And it was shown in programs shortly after that if you sprayed it on the walls as a wettable powder, when the mosquitoes, after they had fed and rested on the walls, that they would die. They would absorb the insecticide through their feet as they were sitting on the walls and die. And in early stage programs, largely led by Soper, they demonstrated amazing successes with indoor residual spraying with DDT, and it were these sort of, starting from 1945 on, a burgeoning enthusiasm to launch a global malaria eradication program based on indoor residual spraying with DDT. And that was formalized by a vote of the World Health Congress in 1955, and it was directed by the World Health Organization. To show you something of what happened as a result of that program, I'm not going to specifically say all of this was a global malaria eradication program, but there was substantial progress made in malaria between 1900. That's a map. It's called the Lysenko map. It was constructed by malaria experts to try and reconstruct what they thought was the range of malaria in 1900. And at the bottom you see the range map of malaria in 2007. And the details of this reconstruction are found in this Nature paper. Gething and Simon are first and last authors. And this massive change was largely driven by the global malaria eradication program, but not all of it. I'm not making that claim. Just a lot of that change, that contraction of the range, happened because of that big program. By some measures, then, it was a huge success. I'm going to say that, and I hope we can have a chance to discuss that statement. But there are two things to note. One is, if it was such a huge success, why did it die in 1969? And I had asked myself this question many, many times, and it dawned on me that the death of the global malaria eradication was the death of a bureaucratic institution, and bureaucracies don't know how to kill themselves, okay? They will persist as long as possible. What actually drove that death was, and I finally found a figure that explained it to my satisfaction, these are the contributions to the special account for malaria. And you'll notice that there are 4 big donations made by the US Congress that essentially finance the global malaria eradication program effort. The last one was made in 1963. And guess when the hand-wringing started about how we're going to keep this program up? It started about 1965 when the budgets ran out. And so it ended by 1969. So the tale of the demise of the global malaria eradication program, many people have said it was about insecticide resistance. That was certainly a problem. That it was about drug resistance. Yes, that was certainly a problem. But bureaucracies don't die because of insecticide and drug resistance. They die because the money runs out. And so the end of the global malaria eradication program was almost certainly about money. So what followed the death of the global malaria eradication program, I'm going to call the age of neglect. Between 1970 and about 2000, it was very hard to get any money to do anything in malaria. And one of the consequences of all of this was a global resurgence of malaria that's been documented. So in sort of dealing with the problem of malaria elimination from Zanzibar, we went back and tried to reconstruct as much as we could of the history of malaria control in Zanzibar, which was marked by 2 previous periods and now the current period of control, followed by these big gaps of no control. And what happens is basically, in the areas in the baseline studies before control is implemented, the prevalence of malaria on the 2 islands, this is Unguja at the top and Pemba at the bottom, were very high. The program came in and crashed the prevalence of malaria to very, very low levels, historically low levels. Then you notice nobody's really looking around. At this point, the Sultan who was in charge said, my people they're too powerful for malaria. We don't need you anymore. The government leaves, the program leaves and it's dismantled, the funding runs out, and malaria comes back. Not as fast as we would have thought in Pemba, but certainly in Unguja. There's a dearth of studies, sometimes very small studies, not nationally representative, and then malaria is obviously back, and the Zanzibar government appeals to the US government, and USAID comes in and they try to control malaria. It didn't do nearly as well as before, declare victory and leave, and almost nobody collects data. In the meantime, before we find one nationally representative survey, and it comes crashing down. The story here being high malaria, come in and do control, low malaria, leave, high malaria, come in and do control, bring it down, maybe not much, come in and do control well and bring it crashing down. When the money goes in, malaria goes down. When the money goes away, malaria comes back. So we did a survey of the literature to find all of the documented resurgence events we could find. This is a paper led by Justin Cohen at Clinton Health Access Initiative. We found 75 documented cases of resurgence, and we asked the simple question, there wasn't enough data in any of those cases to attribute it to a cause, but what causes had been attributed by others? The dominant cause in every case was a breakdown of the national program's ability to distribute, the commodities. When that stopped, malaria came back. Now, there were problems with insecticide and drug resistance, but the dominant, most common thing mentioned was that the program simply stopped doing what it needed to do when malaria came back. I'm simplifying a complicated story here, and I hope you'll give me some license. But by and large, the problem is, if you were to say what kind of resistance, it was donor resistance, or it was resistance is bad management. It wasn't insecticide and drug resistance that was dominating these resurgence events. The other side of this story, though, I think has been less told, and that is in the other countries, the countries that did certify through the WHO process that they had eliminated malaria, you had a very different subsequent history, which is to say malaria didn't come back to those countries. So to try to find some data and document that, we went into the literature and found all of the reported cases we could of imported malaria. So these are countries that, all of these countries had certified that they were malaria-free. And between 1980 and 2010, we could find some of these countries had documented the number of imported malaria cases and then the number of those that had been locally transmitted. So here on a log scale, the size of the box is the number of imported cases, and the color is telling you something about the ratio of local to imported cases. And if you get white, it means that there were no imported cases, and yellows are various degrees of, they're sporadic cases. So for example, for the US, we have about 2,000 cases imported per year and about 5 locally transmitted cases per year. So if we were going to talk in the strict definition of there being zero transmission, the United States has not eliminated malaria. There's obviously still ongoing, very low-level transmission. But if you translate this into a measure of number of cases transmitted per case, it ends up being about 1 case transmitted for every 20 cases imported on average, which means it's very, very stable elimination. So to recap, if countries didn't manage to eliminate, they saw pretty rapid resurgence. Countries that did eliminate it, they saw very stable elimination. So a lot of what we would want to do from a strategic perspective is address this question: how do we make permanent progress? How do we do something that we can then integrate into the national health system and no longer a vertical program with its own budget item and stay where we need to be? That's sort of the big question for, I think, most of the diseases we'd like to work on. In the case of malaria, we want to know why was malaria elimination stable, because that would then direct how we would plan for a program in the future. So one of the things that the major branch points here is whether it was the malaria control programs that caused elimination, or whether there was something else that was happening at the same time, and coincidentally, we were doing those things and malaria went away. So there was certainly economic development in post-World War II, and it could have been the cause of elimination. The other thing, though, is that malaria elimination could have been the cause of economic development, which reinforced elimination. So there's this poverty trap that Jeffrey Sachs has proposed. So if malaria elimination is preventing economic development, and there's certainly lots of data documenting that, then elimination is necessary to spur economic development, and you'd want to do it as a part of a development program, not just as part of a disease elimination program. And that case could be made for all of these diseases, especially the ones that have a big economic impact on productivity or other things. It could be some of these countries had ongoing vector control, but on closer examination of most of these countries, the answer is not much. Some countries like Singapore have an infinitely funded vector control program when they need it, but a lot of the other countries in the world don't. So by and large, there's not ongoing vector control. You could have ongoing suppression of transmission by health systems, that is to say, people who get malaria freak out, get treated early, and it's because of the epidemiology of Plasmodium falciparum, you're treating at a time when there are no mature gametocytes, and you're not yet infectious. So you can knock out most of the infectiousness that would occur by treating very promptly, and so on. So just to bring it to the last age, from 2000 to the future, I'm going to call this the age of declarations. And I don't mean to say anything bad about it, because it's actually been an era of remarkable progress, as I'll show you in a minute. But after that age of neglect, the heads of African states got together and made what's called the Abuja Declaration, and they said, we need to prioritize malaria. And this was in an era when chloroquine resistance was rising and causing a public health crisis. Malaria got a separate treatment under the Millennium Development Goals, and there was a new call from eradication coming initially from the Bill and Melinda Gates Foundation. But let me show you what's happened in malaria. This is a paper that came out last week in Nature, and the story for a long time was that you couldn't do anything about malaria in Africa. Well, that's clearly not true. Here is our best map of malaria in Africa in 2000. And what we're plotting here is the proportion of children aged 2 to 10 who are infected with malaria. And here is that same map in 2015. And that's giving you some notion of how much things changed. And so that if you looked at what the distribution of malaria looked like in red in 2000, it looks like this now. This is a proportion living under each one of those endemicity classes. And you can see there's been a massive shift, and in particular a massive loss of very highly endemic malaria in the populations of the world. This has been caused by the distribution of insecticide-treated nets, the availability of ACTs, and the use of IRS in different portions of that have been caused by each one of those interventions, on top of what looks to be a declining downward trend in malaria. This is a very positive note. It means that we can take a bite out of malaria. We can actually influence malaria in Africa. So just as a note, the global malaria eradication program did almost nothing in Africa. It was intended that soon they would go launch programs in Africa, but they actually didn't do very much. There were some small-scale programs like the one I showed you in Zanzibar, and some trial programs elsewhere. And I think the intention was eventually to get around to Africa, but they didn't by the time the money ran out. Obviously, this time, if we're going to do global malaria eradication, the goal has to be a permanent solution to Africa, where most of the burden is today. And I think that the message of this paper is that it can be done. I will point out, this is one of the supplementary figures, looking at what happens after you do a BedNet program and achieve some level of coverage. So prevalence on the x-axis at the baseline or before the program, prevalence 4 years later on the y-axis, and you can see how coverage at various levels bends that down, but in no cases did we actually document malaria elimination. So I don't think insecticide-treated nets are going to get us across the finish line. So what does the future look like? I don't know, but I don't think that if we want to eradicate malaria, we can rely on an insecticide-treated net program. So we need a new strategy to get us to eliminate malaria in country after country in some regional way that leads to eradication. And I'm talking about Plasmodium falciparum elimination, to be very clear, and possibly Plasmodium vivax elimination after that, leading to Plasmodium falciparum eradication and Plasmodium vivax eradication. But that strategy needs to take into account the fact that we can, by spending money and spending it in the right way, permanently shrink the map of malaria. That does seem to be what the data tell us. And that if we try to rely on control as a strategy, at some point it's likely the money will run out and malaria will come roaring back and be resurgent in these areas if we have a sharp drop-off in funds. So I think as a way forward, it seems to me to be sensible to think about a global malaria eradication program, but we should be very strategic about it so that we don't have this catastrophic loss of funding as they experienced in sort of 1970 when all of a sudden all the enthusiasm for malaria eradication went out the door and there was a sort of an age of neglect. That's my message. Thank you.